Hello, everybody. Thank you so much for joining us for today's webinar. So happy to have all of you on. Um, we're just going to start off with a little bit of a context setting. When you think about doing your manual chart review in your practice, did you know that 40% of a pulmonologist's day typically is lost to manual chart review? And I bet quite a few of you feel that as well. 40%, that's huge. And then on top of that, 50% of pulmonologists report burnout due to bureaucratic tasks like pre-charting as the primary driver. So today we're here to talk about AI solutions. I know we're all hearing quite a lot about AI right now. We are oversaturated with AI solutions. So part of the question is, how do you find an AI solution that's actually built for you and what you do in your day-to-day? Pleased to welcome you all again. My name is Ashley Cheshire. I'm a Senior Product Marketing Manager here at Viz AI, and I am delighted to be joined by Dr. Christopher Hayner from Tri-Health Good Samaritan Hospital, and joined by Dr. Lakshman Swamy from Monogram Health, Harvard Medical School, and Cambridge Health Alliance. We're here to talk about some of the challenges in pulmonary care delivery and how AI might be able to help. We'll talk a little bit about some of the current pressures in pulmonary care, and then we'll move on to Dr. Hayner. We'll cover some of the challenges in pulmonary embolism and acute care delivery. We'll pivot into talking about longitudinal pulmonary care delivery and COPD with Dr. Swamy. And we've reserved actually plenty of time for a moderated Q&A discussion. We have some questions of our own, but we would love to hear any questions that you have along the way. There is a dedicated Q&A window in the bottom of your webinar window. So if you have a question, type it in. If we have time, we will absolutely be taking audience questions, and anything that we can't answer at the end, we will get to you after. So without further ado, I will set us up. So Viz AI, for those who don't know, we are an AI solution. We started in the neuro space for LVO and stroke, but now we're starting to talk about pulmonary. But we are already in 2,000 hospitals across the United States. We were recently rated #1 healthcare AI solution in the Black Book report. This is an independent report for the second year in a row, which we're all super proud of. But Viz does much more than pulmonary care. So if you have any colleagues in the neurology space, cardiology space, and anything that we're talking about today you think could benefit them too, we'd love to talk to them. So with that out of the way, pulmonary care delivery, right? There is fragmentation across the care continuum. And we like to think, or we're observing rather, that we're at an inflection point. There are workforce constraints that limit access and scale to healthcare. We talked about pulmonologists reporting burnout. This impacts your ability to meet patients where they are and deliver the care that the whole reason that you're in the profession that you're in. There are regulatory and cost pressures rising. There are concerns around readmission, for instance, with COPD being part of the readmission reduction program from CMS. There are challenges in oncology with missed lung nodules and some of the implications of missing something potentially cancerous. There are all sorts of pressures pushing on how we deliver care. And these pressures make transformation in how we deliver care urgent. So I won't spend too long, but we are here also to talk about the Viz Pulmonary Suite. So this is a comprehensive AI solution for your whole clinic. We have dedicated solutions for some of the most time-critical care pathway areas like COPD, where we're streamlining post-exacerbation workflows. Our Viz Lung Nodule program surfaces findings for follow-up care. Viz Pulmonary Embolism solution helps accelerate team activations. And on top of all of that, we have pulmonary-specific chart summaries. These are not general. These are designed for pulmonary care so that you can do less pre-charting and do more pulmonology. So without any more ado from me and the marketing spiel, I would very much love to hand it over to Dr. Hayner so we can get a little bit clinical.
Well, thanks, Ashley, and I want to thank Viz and Chest for having me on this webinar today to discuss our experience with AI use in the management of acute PE. As background, I'm a pulmonary critical care physician. I practice in Cincinnati. in a hospital system that operates 6 hospitals, including 2 tertiary care hubs and 4 spoke hospitals. And for some historical background, we've had a sort of a quasi PE response team for about 7 years, but started using an AI-based platform about 3 years ago to really improve the care of the patients in several ways. Next slide. So for starters, I just wanted to quickly remind you of the scope of the problem. There are nearly 1 million venous thrombi cases in the US a year and responsible for at least 200,000 hospitalizations. And I always continue to be amazed when I present the statistics that more people die of PE than HIV, car accidents, and breast cancer combined. And 1/3 of the PEs are related to either recent or current inpatient stays. And so having aggressive thromboprophylaxis built into order sets certainly has reduced significant risks, but that gets countered by the fact that in our haste these days to get patients discharged much sooner than maybe we did 10 years ago, we're leaving a significant number of patients exposed to VTE after they leave the hospital. And what is specifically applicable to the challenges of a PERT team is that over the past 10 to 15 years, we now have newer anticoagulants, variable doses of thrombolytics are being used, and there's a rapid expansion of catheters and medical devices to address PE management. And yet, in spite of this, guideline recommendations have been historically limited by the fact that there are very few large randomized controlled trials. And so over the next 10 to 15 minutes, I hope to make a case as to why AI might be of value in your PE response team. Next slide. Most of you, I'm sure, are familiar with the European Society of Cardiology classification scheme that's been in use for the past several years, which was a significant improvement over the massive versus submassive terminology previously used. And using a combination of blood pressure, PESI score, RV enlargement, and cardiac troponin allows patients to be categorized into one of 4 classes. Fortunately, the low risk group seen at the bottom of the slide in green represents about 2/3 of patients, and the management is straightforward with anticoagulation alone. Similarly, the red or high risk group at the top, which is about 5% of patients at the most, is defined by the presence of hypotension or shock, and treatment here is also pretty well established, with most of these patients either receiving emergent systemic thrombolysis, mechanical circulatory support, and rarely surgical embolectomy. It's the group in the center where the trouble lies. The yellow or intermediate low risk group often behave like low risk patients, and so there's not much of a dilemma here, but the orange group is the intermediate high risk patients, and that's where the problem tends to lie. This group essentially has the features of high-risk PE minus the hypotension. And while they only represent about 15% of PEs, they tend to take up about 80% of PERT discussions. Next slide. When it specifically comes to this intermediate high subset, there are several societies which weigh in on the management. And while they use slightly different wording, they have been remarkably consistent in that this group essentially gets treated no different than any other normotensive PE patient until or unless they decline, and then escalating options can be considered. Next. So this Dilbert cartoon may be a little bit hyperbolic, but not by much. For half a century, there really wasn't much happening beyond heparin and Coumadin, dating all the way back to a Lancet article published in 1960. And then surprisingly, over the next 50 or so years, less than 100 patients had been enrolled in randomized controlled trials. Pytho, which was published in 2014, recruited a little over 1,000 patients and was a major leap forward and showed that improved hemodynamic outcomes in intermediate high-risk patients could be achieved when treated with systemic lytics, but it came at an unacceptable cost of bleeding. And so even though Pytho was sort of cleverly named after the Greek goddess of persuasion, from a practical standpoint, it didn't really greenlight care beyond anticoagulation alone. Next slide. And I say all this because the downside of sort of towing the line with respect to the recommendations comes from this slide. If we were to wait until patients experience hemodynamic decline and then move into the high-risk category before escalating therapy, we're essentially using a 3-fold increase in mortality as our trigger for intervention. The analogy here would be if you called a general surgeon when you approached an acute abdomen case and had them say to get back to you after the patient perforates. It just doesn't seem like a universally good idea. Next slide. And so even if one were to adopt that process across the board, this slide, which is pretty scary, shows how dangerous that can be. And this is actually from a Guyton experiment in the 1950s. And you'll notice the four lines on the bottom of the graph, which represent what happens to the various chamber and vessel pressures as the pulmonary artery is progressively occluded. Now, PE patients obviously don't have Swan-Ganz catheters in place to monitor this in real time, so we're left to just follow the systemic blood pressure, which is shown at the top of the curve. And you can see that through compensatory mechanisms, it holds up quite well until it precipitously declines. Next slide. So if you take that previous graph and juxtapose the subsets that we talked about earlier, you can see the concerns with treating all intermediate high-risk patients as a homogeneous subset. A finite number of them will be subjected to a significant threat of decompensation and worse clinical outcomes. Next slide. So just this spring, the American College of Cardiology released a recategorization of PE risk groups, and they added a new class represented here as D. This group is titled incipient cardiopulmonary failure, and by pulling in transient hypotension and elevated serum lactates, one can now tease out the intermediate high-risk patients that we had previously put all in the same bucket. And I think this has the potential to be a very helpful addition, much like we now use serum lactate levels to affect care in severe sepsis patients. Next. There are even more ways to enrich the assessment and severity of patients beyond the historical parameters of PESI scores, biomarkers, and RV dimensions. There are now a number of low-tech metrics that we've been using locally as a guide for treatment recommendations. Next. Go back to that last slide, I'm sorry. So the serum lactate is certainly one. The shock index is another. We also use it looking at additional CT findings like contrast reflux from the right atrium, the NEWS score, which serially trends vital signs and even ambulating patients within the room. Patients who have significant dyspnea, tachycardia, and presyncope all suggest somewhat of a fixed cardiac output, and a patient who is in more danger than they may appear to be just from observing them at rest. And then most importantly, at the top of the Jenga boxes is arbitrating all these findings with the multidisciplinary PERT group. Next slide. So to be fair, one could argue that the literature doesn't really support any long-term gains from what we do acutely, so why should you subject a patient to the risks and expenses? And certainly the PYTHO study didn't see any discernible differences downstream. But what's not known is if these persistent changes in CPET performance, dyspnea, or the quality of life, which affect up to a third of patients, could be mitigated some if they were better able to be identified up front and focused with advanced therapies in that group. Ongoing studies such as PE track will hopefully shed some light on this and whether upfront therapies beyond anticoagulation alone will reduce the incidence of post-PE impairment. Next slide. So all this brings us to the benefits of a PERT program. And it's important to recognize that since the guidelines generally aren't reissued any sooner than every 3 or 5 years, and studies have shown that a quarter of all recommendations get revised, the guidelines typically lag behind the evidence. And this is where it's important for different disciplines to offer insight and to navigate that evidence to select the most appropriate therapies. And you can see from these bubbles here that with a PE response team, you can get improved risk stratification, a diversity of opinions on the appropriateness of different therapies, implementing evidence-based protocols and pathways, and navigating the gaps in evidence to ultimately provide the patient with the most appropriate care. Next slide. It's been said that if you've seen one PERT, you've seen one PERT, and I think that's probably true. This diagram shows that over a dozen different disciplines can be potentially involved. So regardless of who's a member of your PERT, integration and communication are key to overcoming the major barriers of getting everyone heard and getting everyone aligned. Next slide. So just to recap why a PERT team is important for clinical guidance, because the risk categories have significant in-group heterogeneity. There's a lack of strong evidence for a specific approach, and decisions tend to get made slowly, often in series instead of parallel. Communication can be an issue, especially when you involve 4 to 5 different services, all of whom come at it with somewhat different knowledge level bases. And then also, it's important to be able to measure and monitor outcomes in a more systematic fashion to improve your QI process, as well as improving the consistency of post-PE care after discharge. Next slide. So this slide shows how our PE algorithm worked before we began using AI. And if it looks busy, that's because it was. It's super inefficient. It was not in the least bit timely. Essentially, what the ED would do when they got the results of the CTPA would send out an APB to several different services. Each service seemed to mostly work within their own silos with their resident fellows and attendings, and they would get in and out of the EMR to gather more information. And eventually, if we got lucky, would start touching base with one another. That often occurred later rather than sooner to finally disseminate the plan. Next slide. So we moved over to the Viz PE app, which is a mobile-based platform that bring everybody together from distinct disciplines that we use in managing these cases. And the circle shown at the bottom is how our PERT team is constructed. I'm sure everyone's will be a little bit different, but the point being is that they all share the same information at the same time on the same platform, which is in your pocket, and you don't have to go searching out a laptop with a good signal if you're at a ball game or you're at a recital or you're at dinner or whatever. Next slide. So now this is what we get. Immediate notification of a positive scan. And when I say immediate, I mean most often before the ordering physician even knows the results. We get high quality images that are viewable in different planes, a calculated RV-LV ratio, and a screen that auto imports important labs and allows us to escalate alarms, such as bringing in an ECMO team or a cardiac surgeon for input on patients who have high-risk features. And I think these kind of features are important because it is a way of reducing alarm fatigue. You can set the RV-LV ratio to one that you think is more important to screen patients that may require PERT input. And then most importantly, probably is the screenshot on the far right, which shows a chat room for real-time communication among participants. Next slide. I won't go into any real detail on this slide. It's relatively busy, other than to say this is the reference link that we have in Epic so that every EMR user in our system has access to the same evidence-based algorithm. In a large system, I think there are certainly benefits of standardizing care through this approach, but that still has to be offset to some extent with a personalized approach when necessary. The boxes that are highlighted with the blue background generally show where the PE response team lives. Next slide. And so lastly, how has this technology helped us? Well, we mentioned we get reliable scans to view in almost real time. Studies elsewhere have shown that the wait time to interpretation can be reduced by as much as 2/3. In our experience, time delays between having all the consultants assess the findings and finally go on record as to what the recommendation should be was shaved down from nearly 6 hours to less than 10 minutes. And that's because we were able to do everything in parallel rather than sequentially. Anticoagulation has gotten started over 1 hour sooner. And data on that previously published has shown that the sooner you can identify a patient to treat and the sooner you can get treatment initiated, the better the 30-day outcomes will be. There have also been multiple other studies looking at length of stay, both hospital and ICU, which are generally positive. We do, however, say that more data is needed to assess the impact on mortality and long-term outcomes. But in conclusion, I think that acute PE is a particularly fertile ground for AI, where rapid, immediate access to data are necessary, multiple disciplines are required to weigh in real time, and a time-sensitive decision is needed. Thank you.
Thank you so much, Dr. Hayner. I love that you had brought up the need for appropriate follow-up care and what follow-up can look like when you catch PE early and what an impact that has on quality of life for the patient and ongoing care. I think that transition sometimes between those acute events and making sure that the right follow-up is happening to improve patient quality of life is so critical and can be challenging when these things are happening sequentially and not in parallel. So I'm going to hand it over to Dr. Swamy. We're going to talk a little bit about that problem, but in the context of COPD. Dr. Swamy?
Yeah, thanks so much for having me. So I'll be talking about COPD and longitudinal pulmonary care, so very different than the acute care, although in many cases there's so many parallels, as I think you'll see here, and what AI can do. So I wear a number of different hats. I'm the chief pulmonologist for Monogram Health, a value-based care company. I see patients across the country for that. I teach at Harvard Medical School, and I practice pulmonary critical care medicine in Cambridge. And I'm the editor for the American Journal of Critical Care. All of those actually kind of feed into what I'll be talking about today. This is really my passion, is kind of improving population health for patients with COPD. And I think the latest guidelines and all of this kind of like really feed towards that. So it's a very exciting time for me and my interests. Many of you already know this, I'm sure, but COPD is a massive burden of disease, right? Huge cause of global mortality. Many patients with COPD who are admitted for acute exacerbation are readmitted within 30 days. And we know that they're not always readmitted for COPD exacerbation again. We know that COPD exacerbation is kind of the tip of the iceberg, and patients have so many other problems that they can come in with as well. Huge financial costs in healthcare from this. And I think all of us who take care of patients in the hospital or out know that there's a feeling of, it's very hard to get people access to pulmonary care. Less than 20%, as you can see, of patients have pulmonary follow-up after a discharge for acute exacerbation. And in the moment, it might seem like, well, what are we going to do? They're on their inhalers, they're this and that anyway. But as you'll see, there's so much that can and needs to be done for patients who are that sick. Okay, next slide, please. So we follow the the expert consensus guidelines. And when I read the guidelines each year, I read them this year. This is sort of my big picture sort of takeaway of the GOLD guidelines. We want to reduce the risk of people developing or worsening COPD wherever we can. We want to identify patients. This is a big emphasis in the newer sets of guidelines here. Identify patients who have COPD through a risk stratified active case finding approach. That's a lot of words, but what this means is that we want to go out into the population. We want to find people who have risk factors for COPD, especially there's a study in 2024 in the New England Journal, where they robocalled a lot of patients in Canada, and patients who had pulmonary respiratory symptoms, right? And risk factors, they got them in to do spirometry. And then once they had spirometry results, they split them up into either an intervention group where it was pulmonary driven, not necessarily seeing a pulmonologist, but pulmonary driven care versus usual care through primary care. And there were big differences in rates of hospitalization and all that. I'm so sorry. I just realized I'm talking about this and I don't have the citation up here, but we'll grab that for you. So it's important to have this kind of like approach where you go out there and find people with COPD, because otherwise they come to us too late. We need to be proactive about it. We need to get a lot more spirometry done than we do. There's lots of challenges there that we'll talk about. So once we know that patients have COPD, we want to optimize the treatment of their disease and the management, right? And there's challenges there. And then another big emphasis coming out now is to address comorbid disease, cardiac, psychiatric, metabolic syndromes in patients with COPD. And I think this is really important that we're seeing this from the perspective of the GOLD guidelines and from the pulmonary societies as well. All right, next slide, please. So the problem with achieving these goals is that COPD is underdiagnosed, misdiagnosed, huge proportion of missed diagnoses in COPD, especially when you look at a geriatric kind of polychronic population. And this is due to so many factors. On the patient side, people so often think that it's just that I'm getting older, and so I'm getting short of breath. And they curtail their activities substantially. They're doing less and less and less, and then suddenly they get sick and their breathing's never the same again. What happened, doc? It all started with that one cold, that one pneumonia, whatever. But really, we know that it had been going on for a long time. There's poor access to getting spirometry done in the first place, and poor access to pulmonary subspecialty care. And then there's a poor understanding of the latest COPD diagnostic criteria and management. And this is in the generalist population, in ED, in primary care, and even in the pulmonary population, the standards have changed quite a bit, right? COPD is under and mistreated often. We talk a lot about smoking cessation, but it is not really easy to achieve as a checkbox. It's very high touch kind of care. And I think although rates of smoking, especially in America, are going down a lot, rates of vaping are going up. And I think we don't do a great job dealing with the emotional aspect of smoking and going to where our patients are. I can't tell you how many times I have seen a patient where every note in the chart says patient is pre-contemplative, has no interest in quitting smoking. And within just a couple of minutes of talking to them, they're ready to try Chantix or something, right? Like they've always wanted to quit. It's just that many people approach it as kind of saying, don't you know how bad it is for you? So we're not doing great with smoking cessation. I think we can do a lot better. There's so many challenges with prescribing inhalers, right? Very often we prescribe an inhaler. We don't know how much it's going to cost the patient. That's a huge challenge. Formularies and all of this. I can, so many patients that I would love to have them on LABA/LAMA, but I end up on LABA/ICS, right? Because that's the only thing their formula cover. There are patients that I have on Duonebs 4 times a day because they can't afford anything else. We know that that's not going to work as well, right? And when people get inhalers, the adherence and technique are really lacking as well. It needs a lot of high touch kind of teaching and training and spacer use. And then on the other end of the spectrum, advanced therapies are considered often very far too late, if at all. This is everything from biologic therapy for the right patient to surgical intervention. That requires such a solid foundation of defragmented care underneath to get there, and we often don't have that. Vaccination challenges. When I approach patients for many years out of training, I thought that the challenge would be that people are vaccine hesitant or skeptical. Actually, it's very often not that. It's very often that they don't have transportation. They don't have a way of getting it done. They don't know what they've gotten or not gotten. And so there's these kind of fragmented care issues that we face there. And then pulmonary rehab, palliative care, extremely underutilized. These are conversations that should be happening up front with the diagnosis, so people have an idea of the functional impairments that they're going to be having in the natural course of disease. And as I mentioned several times, I'm going to keep talking about is the comorbid disease that goes along with COPD, underdiagnosed and undertreated. Next slide, please. Thank you. So part of the solution certainly can be AI. There's a new chapter in the GOLD guidelines about AI. I think, was there one more slide before this one? Maybe not. Yes. Okay. So there's a new chapter in the GOLD guidelines about this. AI can have a role in identifying individuals at risk. So this is going through your health system's charts, data, and all this fragmented data and pulling it together and saying like, this person is really high risk. We should reach out to them. We should get them in. We should get them tested. So stratifying that and then being proactive, right? Reducing misdiagnosis through automated interpretations, diagnostic suggestions. And then I like the sentence from the GOLD report. This is in response to managing comorbid disease. This is a Herculean process where AI can be of great help. And it's just like Dr. Hayner said, this is not about AI telling us what to do for the patient, right? It's actually about helping defragment and connect the dots so that things can actually get done for the patient. So this is addressing everything from like polypharmacy, the comorbid stuff, missing testing, just gaps in the treatment and the diagnosis, and optimizing vaccines. Next slide, please. So it can, I think a really important part of this is this synthesis, right? Cleaning up the data, this ambient pre-charting piece of pulling together the documentation, putting everything in one place for us to see that can, of course, reduce the amount of like pajama time and all of that. And how much time do I spend digging through charts to kind of figure out what's really going on with someone? But then also enabling action, right? Like that is like a springboard, a trampoline, a platform to launch us into getting things done. Now, this is so important because in the absence of that, in the traditional system, very often it'll be like, well, I've gotten through what chart prep I can. I've understood what I can about this person. They have so many gaps in their testing. They don't have PFTs. They don't have an echo. They don't have this. They don't have that. I'm just going to do what I can in this one initial short visit I have where I'm trying to get to know them, trying to build trust, trying to get the understanding of their experience of their disease and get something moving. I just want to get the train moving, right? And then I'll see them again in a few months. I'll see them again in a few months. Radically different if you can condense a lot of that so that you can see what has to be done and getting it done up front. Even more different if some of that is done before. Next slide. So focusing on the comorbid disease. So some of these statistics in the Gold Report are just really striking. And I think it again shows that my job in taking care of patients with COPD is not managing the lungs, right? My job is optimizing their outcomes for the entirety of their lives, right? This is longitudinal management of chronic irreversible disease process, right? This is what we do as internists. So some of these stats are really relevant and challenging for me to face even. For a year after a COPD exacerbation, especially if hospitalized, significantly increased risk of cardiovascular events, unstable angina, TIA, all the way through stroke, MI, death. So that means when we are discharging that patient with COPD exacerbation, they're back to their kind of baseline afterwards, they're off their taper, things seem to be going okay. Well, actually inside that body, there's a lot that's maybe not going okay that we need to be aware of. The risks are very high of things going wrong in the next 12 months or more. Can you imagine that? That's 11, 12 months after a hospitalization for an exacerbation, you're having an MI. It's pretty striking to me. Heart failure frequently underdiagnosed, independently associated with worse outcomes. This really was like a gut punch when I read it. This paper it's really heartbreaking. People with COPD are twice as likely to die by suicide as those without COPD. I don't think I'm the best to manage this. Right? I want to do right by my patients, and I kind of have to know my limits too. I want to be able to recognize this where I can. I want to do what I can. And this is heartbreaking when this happens in your patient population, right? For us, but of course for everyone in their lives. So many of these conditions are treatable, right? But if they're not treated, even these are kind of extremes. There's still, we see just sarcopenia, sleep-related disorders, renal failure, not just, but they're more and more chronic burden of disease that causes really significantly reduced quality of life, more acute care use, worse across the board. Next slide, please. So what can AI do? So I think it can help in many different aspects of the care here. So this risk stratification piece is huge. Go out and find the people so that I don't have to wait for them to come to me too late in their disease course, right? Getting to people early and helping them quit smoking early makes a massive difference. That's something our health system can do that doesn't do that well. That risk triage, rapid intervention, pulling people into clinic and getting things done. Now, I've written this as assistance for generalists, right? Because if someone comes into the ED with COPD exacerbation, whatever, or they're going to see the primary care doctor, it is too much to ask for a generalist to be aware of all of the updated guidelines for every condition they manage. That's a huge ask, right? And yet, if we can, what I often hear from my colleagues in general medicine is that it's not easy to know which inhaler to prescribe. Now, inhalers, as one of my good friends is a COPD genomics researcher, and he told me it's like talking about inhalers for COPD is like bringing a knife to a bazooka fight. Inhalers are important. They can really improve quality of life. They can improve how much you can do every day, your symptoms. They can improve, reduce exacerbations, all of that stuff. They're important, but they don't cure COPD, right? They're the tip of the iceberg. But this is what non-pulmonologists often think of first, is like they need an inhaler, they need a puffer, right? But even that, they struggle with prescribing because of all of the different devices, medications, the formularies and all of that. Well, just getting them some basics on guideline-based care and saying like, start something, right? Because when I know from my experience, if I'm seeing a patient, it is such an acceleration for them to come to me already saying, well, doc, I tried this inhaler and I couldn't get it. It was too expensive. Or I've been using it. It's doing nothing. And I can say, show me how you use it or whatever, right? It's so much more to work with. I'm so much further ahead than if I'm starting with the first inhaler, right? It really matters to me a lot less about it matters mostly the guideline for what inhaler is best for the patient is what inhaler they can afford and actually get. So that's kind of my perspective on it. And I think that it can help push that out and help encourage them to enact some of this guideline-based care. I really think rescue packs are really underused. This is getting someone a burst of prednisone to keep on hand, maybe a course of azithromycin. This is for patients who are really high risk, who are frequently using this stuff anyway, and they're going to get it anyway. All of this can be done ahead of time, and they can still, then get through that delay to getting to see us and all of that. And then the chart analysis, like pre-chart, and then also figure out the same thing that this AI system can do for generalists and helping them know the GOLD guidelines and all of this and getting stuff off to a start. It can do for me for the cardiovascular disease, for the psychiatric disease, for the metabolic syndromes, right? It can help me say like, hey, get this testing done. This person actually does need, whatever other referral, and help make that happen where I might not have thought of it, right? Because I have a lot to do, a lot of patients, very little time. And it can really just turn these guidelines into orders and prompt us to get medications ordered, to get testing ordered, to get referrals in the system, and expedite and connect some of this care coordination. Part of the reason that this comorbid disease stuff is so important is that, on the one hand, people who have COPD, the same risk factors, perhaps tobacco smoke, that led them to get COPD, will put them at risk for cardiovascular disease, for stroke, for all this other stuff, right? But the other side of it is that when people have significant COPD, the reduced pulmonary function, the reduced pulmonary reserve, means that if they have heart failure, just a touch of pulmonary edema is going to do a lot more damage to someone with significant COPD than not. So the interaction between these systems is really profound. We see it every day. And I think really trying to see the whole patient in this perspective is important. Next slide, please. So, with these systems in place, I really believe it's possible to leverage AI to help us reduce symptoms, identify and manage social determinants of health, even improve quality of life, reduce exacerbations, improve outcomes, improve disease management, reduce acute care needs, reduce the cost of care. And again, this is all in this new chapter, chapter 6 in the GOLD guidelines. It's a short read. I really recommend checking it out. Next slide. So the current state for many of us in pulmonary practice is reactive, right? We are taking care of the people who show up in front of us. They turn up maybe in the ED seeking or urgent care or something, or they're referred maybe by PCP to us, and then we are taking them in and seeing who's there. There's a real big burden on us for chart review and prep. This is, you heard about some of the stats. This is the lived experience for all of us, right? How much time it takes. You can't do it during the visit. That patient expects you, understandably, like rightfully expects you to already know what's going on with them before you sit down with them. And you have so much to do with them in that room. You need to know what's going on with them before. That's a huge amount of work. And then most of the care that's available right now is what's available on site. If you have point of care spirometry in your clinic, your patients are all getting spirometry. If you don't, it's very hard to get them spirometry. You got to get them full PFTs. There's delays, there's costs, all kinds of stuff, right? Inhaler teaching, very clinician and site dependent. And some of the best clinics I've worked in, I remember when I worked at VA, I would prescribe something, patient would walk down the hall, go pick up the prescription, come back and sit with the nurse and get inhaler teaching before they left. That's pretty amazing, right? There's a much higher chance that they're going to be better off using it, knowing when to use it and how to use it, what to expect from using their inhalers and all of that. But that's hard. It's hard to manage, right? It's hard to know how to get all of that done. And the workup or treatment for all these other comorbid conditions really relies on a single clinician, and it's often punted to like the PCP. That's a big load for a PCP who's also not necessarily seeing the patient as frequently as some of the subspecialists are. Next slide, please. So what I really anticipate is that there's a future state that's much better, where we're proactive with our care for people with COPD and chronic pulmonary disease. Again, the AI-supported risk stratification, pull in all this fragmented data, the EHR, pharmacy data, urgent care calls, remote patient monitoring data, maybe symptom screening robocalls, call the whole patient catchment area and say, like, are you having these symptoms? If you are, we'll plug you in. It might support connecting back then into the clinic to get the spirometry done very quickly, to diagnose, grade the COPD. In my company, we do in-home spirometry to get all of this done for people. And then finding out the objective and subjective data, putting all of that together, can support triaging patients for primary care with AI-assisted guidelines versus getting them prioritizing for subspecialist care, so that people are really getting care where they need it quickly, right? Getting the level of care they need at the time they need it more and more efficiently. And then this pre-charting piece, it's not, I think that, as a clinician, it's huge in how much time and effort it saves. And one of the nice things about it is that in this use case of AI, it's not a black box. It's not telling me, hey, you should do this. Like some of the stuff I've piloted or looked at in the ICU is kind of like, I think you should give fluids. Why do you think I should give fluids? I think you should give fluids. Okay, that's not that helpful sometimes, right? But in this case, it's saying, here's what's going on with this patient, and you can just follow it back to the source of the data. It's just compiling the data, and it's doing a huge amount of labor, but it's not doing a ton of generative work, right? It's synthesizing it, it's putting it all in front of you in a package. You can trust it because you can go back and see the source. It's not like making things up or telling you what to do. And it's telling you, here's the guideline, this is what we suggest, blah, 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 because of this patient. And then the referrals are also a big piece here. This referral piece is really important too, because it gets things done for the patient, but it does a little bit more than that too. And you can see that, less respiratory illness visits, more improvement in FEV1 and all of that. Next slide, please. So this is, kind of to conclude, I think that AI actually helps at many levels here. I think it really helps patients to get more patient-centered care. Healthcare is finding you instead of waiting for you to get sick, waiting for you to overcome the innumerable barriers of getting scheduled and getting into clinic, right? It's triaging you out there in your home instead of waiting. And it's connecting you to who you need. It's like overcoming a lot of the bureaucracy and paperwork to say, like, you actually need to see a cardiologist. We're going to get you into Card's clinic. We're going to take care of all of this stuff for you. We're going to defragment, connect the dots, right? Less work for the patient. Patients, I know as a patient, they have to do so much work. It's so much work to get care, right? For clinicians, wow, how much help is this chart synthesis going to help with just reducing the amount of time, presenting it to me like as if I always have a fellow who's done all the digging and saying, here's the data, here's what, and then recognizing the treatments outside of my scope of expertise and helping me enable getting things done for the patient, making it easier for me to own that responsibility for the patient's global outcomes and not just for their lungs, right? And then for the healthcare system, this is really important that it supports more internal referrals. It reduces that leakage where people are seeking care elsewhere because they went to that urgent care instead and they got their care there. And then it's a hassle for everyone because their chart is over there, their testing is over there, their care is over here. And it enables more and more of that care to be provided internally and synergistically. All right. I think that's my last slide.
I was most struck by the discussion around guidelines and the care and being able to trace back, right, to where the recommendations are coming from in the AI. One of the things we've really tried to do with Viz COPD specifically is make sure that the GOLD report is part of what we surface. So that's built in and part of the tool. So that the recommendations are coming directly from the GOLD report. They're linked, and the information is also linked back into the EHR, right, where the product found the patient info that is related to that guideline. I was doing some research for a different project, and I was looking at how many guidelines just in general were produced in 2025 alone. And this is not just pulmonary, but in 2025, the US clinical guidelines cataloged 400 new guidelines in a single year. And this is across all of healthcare. So then I went to look at pulmonary specific, which kind of expands out into cardiology and pulmonary and these comorbid type areas. But even then, about 59 new guidelines were produced last year. And that's just 1 year. And that's so much to keep track of. These patients are complex, the comorbidity burden. It's just really striking to me. So, in any case, we're ready to move into our moderated Q&A. We have just about a good 15 minutes left for this. I have some of my own questions, but if any of you have questions along the way, feel free to drop them in the dedicated Q&A box. And if I can, I'll bring them into the discussion. And if I can't, we'll make sure that they get answered. So let's start maybe with Dr. Hayner. We'll go back to you. So when you're thinking about the coordination that needs to happen between acute events like a PE finding or a COPD acute exacerbation, and then getting that patient to the necessary follow-up or long-term care, where do you see the biggest breakdowns or weak points in the coordination that's needed to make sure the patients move to the right workflow or the right care path?
I think a lot of that sort of depends upon communication, and it's easy to go back and oftentimes, in the hospital, especially when we're dealing with residents, the solution to any problem that comes up is always communication. And I think that's the case as well, because patients do have care fragmented in the hospital. They have care fragmented, when they go out to the floors, and the hospitalists work different shifts. And so they may see 2 or 3 different physicians during the course of a 5-day stay. And then they go back to the primary care doc, who may or may not have a timely update on what happened and what took place in the hospital. And so it's always hard to put those pieces together. And so I think on the inpatient side, having handoffs, where you provide not just an overview of what happened, but also if-then scenarios and things that you talked about that maybe didn't make it into the medical record, to make sure that when a patient transitions from the ICU to the floor or the floor to home, that they have, that the providers have a feel for what's going on. And then I think having social services see the patients before discharge, so that we can make sure that they didn't just come out of the hospital with a stack of papers and a couple of prescriptions, but they actually know what to do with them. And that's a challenge, whether you're talking about COPD, PE, congestive heart failure, any inpatient stay, just sort of working them through the process and having an appropriate landing is super important. And sounds easy, but boy, there's a lot that can go wrong in that scenario.
No, that's a good point. We can do as much as we want to do to make our workflows better, but that patient education piece has to be there, because patients also have to opt into their follow-up. Dr. Swamy, what about you? Where do you see the biggest breakdown in these workflows?
Yeah, I think the challenges that I see are again, fragmentation of care is the everyday lived experience of every patient. It's the normal state, right? Again, like Dr. Hayner is saying, even within an inpatient stay, that's like as internal as it gets, and still the care is fragmented and it's not easy to connect the dots. And that's really magnified dramatically when you're getting care in different places. So as the clinician who's trying to put together the pieces in a very short piece of time and try to figure out what to do for a patient, I'll say that the worst thing that happens is when we end up punting things, right? I hate punting care. I hate punting things where it's kind of like, oh, well, I didn't get to smoking cessation today, so I'll mention it, but then we'll punt it to the next visit. So I'm punting to myself in the future, and then I'm punting to other doctors to say, I'll send a message to the primary care doctor and say, hey, could you figure out what's going on with this patient for something like this? And if you, what is a way that could be different? Well, first of all, just the efficiency that is gained to have high touch time this is like the high touch, high tech interaction, where the high touch part is what really matters to get patient care done. But the tech is so messed up right now. The data is so much that using a high tech solution to clean that up and make it efficient then allows that the high touch piece to come into play, because that's how you get care done for people, right? It's not going to work for me to just throw them all the prescriptions and say, look, I checked all the boxes, right? I need to talk to them about palliative care from day one, for example. All this stuff is very high touch. And a big part of it is, I was just thinking while I was listening, is when I'm not comfortable with prescribing GLP-1s. That wasn't something that I was doing when I was in training. It's kind of it really came out after that. It's not something I've done much of. I probably should be. I probably should get there. But in the meantime, how nice would it be if the system says to me, hey, this person is a really good candidate for a GLP-1. Here's the things you should just ask them. And even if you don't want to prescribe it, now we have enough data after you talking to the patient that we can not punt it, but and like collaborate better to get this thing done for the patient without needing another visit scheduled with another clinician in the future, right? Like there's ways to really emphasize, like to get a lot more done out of a single encounter in that way without the other people even being in the room.
Mm-hmm. Yeah, you bring up a good point. GLP-1s are new. There are a lot of evolving expectations that are entering into your care space. Dr. Hayner, you were discussing the new PE guidelines that were just released in February by the American Cardiology Group, ACC. I'm wondering, from your perspective, as expectations evolve, what is becoming harder to operationalize consistently? Where does consistency break down with these new expectations for you?
Well, I think the big issue is that we still put people in large buckets because it's easier than putting them in smaller buckets. And that's where we need to really sort of focus our attention. I certainly don't advocate that every intermediate high-risk patient receives mechanical thrombectomy or catheter-directed lysis. But by the same token, they don't all receive just Lovenox and Eliquis. And I think that's where, through a multidisciplinary team and getting people together and teasing out which of these patients in the intermediate high-risk box are going to behave much closer to the high-risk group, and not let that happen and intervene. And I think because the data, which, although the studies that are currently being done appear to be phenomenally well designed and will answer many of the questions that we haven't had answered for years, it's still not as prescriptive as it needs to be. And it still just goes back to decision making in conjunction with a group of people who all bring something to the table.
Thank you. Back to Dr. Swamy for a minute. I've got a question in the chat from Ryan Template. He says, Dr. Swamy, you mentioned AI's role in risk stratification and proactively identifying high-risk patients. Can current AI models reliably predict when a COPD exacerbation is about to happen, not just who is at risk? I know for a Viz COPD solution, it's not a predictive solution in that way, right? It's not able to monitor patients who aren't currently in the healthcare system, and it's not set to predict. But what it can do is look at history of past exacerbations and flag whether they are at higher risk for readmission. I'm curious, from what you've seen, Dr. Swamy, how do you see AI continuing to support this issue?
Yeah, absolutely. And I apologize for typing because I was typing out an answer to this question. But so this is much easier, actually. So I can combine it with the question about, can AI replace the spirometer? So here's the thing. Let's focus on this piece about predicting a COPD exacerbation. There's a lot of interest in that, in saying like, oh, if I only knew, then I would be able to do something for these patients. And then my question is, like, what would you do? Would you call them and say, how are you feeling? Oh, you're starting to feel bad. Would you bring them into the office? Would you prescribe them a rescue pack? The thing is that I think that actually the huge benefit is way earlier, like you're saying, actually. The prediction of this decompensation, it's better to have systems in place to take that in and help people. Way better if you say, as we do in my clinical practice, we give people the rescue meds and the phone number for our acute care line is on it. So they have a COPD action plan. They're starting to feel short of breath. They can look at the pills. They look at the number. They call. Someone guides them through it, right? Because it's very hard to get them in, and it's not really helping if you're just going to call them and say, oh, you need to go to the ER, you need to go to urgent care. That's not really helping anyone. Like, that's what they're going to do anyway, right? So I think that the benefit is really on the other end of saying, let's get them set up with everything they need. Let's get them to understand their disease. Let's get them the tools they need to manage it, because it's very hard to get people in on the spot and maybe not that beneficial. It's way more beneficial to prep them. Now, the remote patient monitoring data is huge, and this goes with the question about the spirometer. When I think of AI, the old saying saying is still true. Garbage in, garbage out. The other side of that is also true. If you put treasure in, you get treasure out. And I think when you have AI leveraging off of really high quality data, it's going to do incredible things, right? It's such a force multiplier there. Spirometry data that's high quality is really valuable physiologic data. We should be getting more of it. The solutions are getting easier to implement and get out there. I think it's critical. It's not going to suddenly go away. You could risk stratify and say this person's really likely to have COPD, and in a resource limited setting or whatever, sure, start treating them. But COPD treatment is longitudinal and it's really intensive. It actually takes a lot of care to get people everything that they need. So it's not a quick thing. It's like if you're asking, can I prescribe someone a long-acting inhaler based on that? Sure. Is that treating their COPD? Not at all. There's so much more to do. So I think remote patient monitoring actually really can play a very powerful role in this. Point of care devices like point of care spirometry can. When you're looking at, there's remote patient monitoring I've looked at that really can predict COPD exacerbations, heart failure exacerbations well in advance. The question is, do you have the health system in place to react to that and to respond to it and to get them what they need? And are you still trying to build an acute care responsive system instead of a preventative care, preventative system, right? A system that's really helping people not let them get there in the first place as much.
Perfect. I've got two main things that struck me from what you were just saying, Dr. Swamy. One is that the patients don't need the AI to do your job. The patients want you. The AI is here to help you and to help you do that better so that you can give patients the attention they're hoping for that you want to give. But the AI can't do what you do. It can support. Just like AI can't do spirometry, at least at this point, until somebody designs a robot to go do the test. But AI relies on those spirometry results to surface things that are beneficial for you. I've got one chat question for Dr. Hayner. It looks like it says one of your old residents from way back. He says there's quite a bit of variability with RV-LV ratio from the CT to the echo. So they're wondering, do all patients get a stat echo with your PERT team before a game plan is made? Is that part of your workflow?
Not necessarily. I think it is if obviously it is if somebody's going to be going on to mechanical circulatory support. It may be if we have significant abnormal features on the CT scan that the interventionalist wants to have a better assessment as to whether they can mitigate complications by not putting a stiff wire in a ventricle that's failing more than we would recognize from CT alone. But I don't think it's necessarily. I think that we use the CT scan not just for the RV-LV ratio. We certainly look at contrast reflux. We look at septal shift. We look at PA size. The difficulty sometimes becomes in patients who have pre-existent right ventricular hypertrophy or enlargement, significant sleep apnea, significant COPD, and trying to decide when we think that elevated RV-LV ratio is an acute process or whether that's something that's related to a longer standing comorbidity. So I think we will use it more often than not, but it's not a requirement prior to interventions. Perfect.
Thank you so much. I've got one question to wrap up with that I'm going to ask to each of you. So I think I'll start with Dr. Swamy. Thinking about technology, what does technology need to do to be genuinely useful rather than just adding noise?
Yeah. I think it's such an on-point question because I can say that through my entire time in healthcare, from the first days as a medical student to now, technology has hindered more than helped. I mean, it has helped a ton. I've also gotten very used to charting electronically and reading notes. I remember when I was a medical student working places where we had paper charts and it was also really bad. So I'm not saying this is it's just a bad thing, but it has hindered a lot on its way to helping. The amount of data to digest whether I'm in a pulmonary clinic or I'm in the ICU is just enormous. It's really hard to do that in a timely fashion. And it's really hard to teach that as well. So I think that the biggest thing is to manage the amount of data in a way that is trustworthy and as much as possible transparent, because it's also been true. My experience of AI has been like this, as well as my experience of just using an EMR and everything is I'm really scared when I'm making decisions for patients, with often their lives are on the line. Can I trust the thing I'm looking at? And that is a big challenge. So I would say the ease of use and the trustworthiness and the transparency are that's got to be of paramount importance.
Agreed. We can't have a black box because then how are you able to make the decisions you need to be made? We need to have it all visible, right? How we're
Right.
building these algorithms, where the information is coming from, what sources or guidelines or peer-reviewed journals are involved in recommendations that are surfaced. Dr. Hayner, in your opinion, what does technology need to do to be genuinely useful and not just add more noise to your workflow?
So I'm old enough to have started with life with paper charts. So from that standpoint, I think the EMR is an extraordinary repository of data. It has everything you need in it. The problem is that it's an extraordinary repository of data that has everything you need in it. And I think it's very frustrating to try to find that needle in the haystack, and having a tool that can cull that information out, like Dr. Swamy mentioned, with not doing your work for you, but actually presenting the information in a way that makes your job more efficient, and makes for greater patient safety and greater patient care. I think that's the holy grail to helping get through the day as a pulmonologist, and also providing better patient care.
Love it. Thank you so much. That's the perfect segue for the last single minute of our presentation. I just want to talk again briefly about the Viz Pulmonary Suite because ultimately this is what we're trying to do. We're trying to reduce some of the noise with this surplus of AI tools and bring something that's going to be actually valuable, that's focused to pulmonary care, where the pre-charting, the AI-assisted summaries are specific to pulmonary disease and not just general. So it's looking through these oceans of EHR data for you so that you don't have to spend all the time doing it. But if you want to drill down, you can figure out where it came from. Ultimately, less pre-charting, more pulmonology, right? I know we're right at time, so I'm just going to skip ahead to say, please come and see us. Viz AI will be at both ATS coming up in May in Orlando, and we'll also be at the CHEST conference in October. We're really looking forward to being there with our full suite of AI solutions. Thank you, everybody, for your attention, for your questions. Thank you, Dr. Swamy and Dr. Hayner, for joining me and offering your clinical expertise. I could talk about Viz all day, but they don't want to hear me talk about Viz all day. We need to talk about what's actually happening in your clinical workflows. So thank you, everybody. If you have questions, look for Viz AI. Our website is literally viz.ai. We would love to hear from you and love to answer any other questions you have about the Viz Pulmonary Suite and be part of the discussion. Thank you, everybody.
Thank you.
Thank you. Hope to see you all at Chest.